Hello and welcome back to another anaesthesia step-by-step tutorial. Today we're looking at massive blood loss. As always, you're in theatre having anaesthetised your patient like a pro, and the surgeon is doing surgical things, when suddenly it all goes rather quiet, and the surgeon alerts you to the fact that the patient is bleeding heavily. What should you do? The first step in this scenario is to call for help because you're definitely going to need more hands to help out. This might mean pulling the emergency buzzer if needed, and make sure you ask someone to grab the quick reference handbook. Your first priority is delivery of oxygen to the tissues, which is going to be badly affected by major hemorrhage, so increase the FiO2 to 100% to offset this as much as possible. You may also consider cautiously reducing your sedation so as not to worsen hypotension, however the risk of awareness needs to be considered. Now the next 3 steps should all happen as simultaneously as possible. You're going to need some serious IV access, ideally 2 orange cannulas or as close as you can get to this. This may involve diving under the drapes to get an arm out for extra access, so ask a theatre team member to get an arm board if that will help. While you're doing this, the surgeon is hopefully trying to stop the bleeding. Usually the anaesthetist can't get too actively involved in stemming the blood loss, but it's helpful to think about how you might aid the surgeon in achieving hemostasis, especially if you can give a drug such as syntocinon for uterine contraction that might help, depending on where the blood's coming from. If the bleeding continues, activate the major hemorrhage protocol. Your hospital will have a bleep or a crash call system to facilitate rapid delivery of blood products to the patient. The key is to let them know as soon as possible. You will also want to send someone to get the level 1 rapid infuser or Belmont that allows fast, warm delivery of blood products. While the blood is on the way, you need to think about warming your patient up. They're going to get cold as they lose blood volume, and this is bad news for major hemorrhage, as the triad of hypothermia, acidosis, and coagulopathy will lead to a disseminated intravascular coagulopathy and death if not prevented. Heating pads, forced air warmers, whatever you can, use it to keep them warm. Once the blood arrives, you'll need several sets of hands checking and setting up the blood delivery. Ideally, you should outsource this to other members of staff to allow you to focus on the patient. Once the blood is running in, it's time to start thinking about the other drugs you can give to help with the clotting cascade, including tranexamic acid, calcium, and things like Beriplex or prothrombin complex concentrate. The key here is good communication. Communicate with your surgeon to establish how severe the bleeding is, how much the patient has lost, and how long it's likely to take to fix the issue. Do they need extra help that you could call someone to come and help them? Remember, they are likely to be extremely task-focused, and so you might have to proactively suggest things for them. Keep checking with the theatre staff what has been given and whether more blood or help is on the way. It is likely this patient will end up needing intensive care, so let the team know early, as they can often come and help as well. It's also often a good idea to discuss with haematology, as they can guide you on how best to manage severe bleeding, especially once you've given several rounds of blood and fresh frozen plasma. If you've done all this and the bleeding is ongoing, it's time to start thinking about other options such as cell salvage and contacting interventional radiology if they're available on site. Throughout this process, it's important to reassess, to see what progress you're making and how the patient is responding. Send off a set of bloods and a blood gas to assess hemoglobin, lactate, clotting, calcium and fibrinogen levels, as these are all reversible issues that you can optimize as needed. The numbers you're aiming for are a hemoglobin above 80, platelets above 75, a normal clotting profile, and fibrinogen above 1. Your primary goal is avoiding DIC. As always, the key with these emergencies is knowing when to call for help and using the quick reference handbook to guide you so you don't miss any steps. I hope this has been useful. Please like and subscribe as it helps us to spread this tutorial and help other people, and we'll see you next time.